All right, how's everybody doing? We've got the illustrious Curtiss Stinis with us today. Curtiss is a clinical professor of medicine at Scripps Clinic. He's also the director of peripheral interventions and the fellowship program director. He's also the voice in my head whenever I do cases because Curtiss trained Aiden and I. He is an incredibly talented interventionalist, probably the best I've ever worked with. And we're really honored to have him today and talk about lifetime management of aortic stenosis. So Curtiss, take it away, bud.
Well, thank you for that unnecessarily kind introduction there, Joe. Really appreciate it. I want to talk about a subject which I think we need to spend more time thinking about in general in our practice, which is the lifetime management of aortic stenosis. And I think there's a few things that we should really be considering when we're looking at patients. And, we all know about the guidelines. And importantly, the guidelines talk about, surgery for younger folks and potentially TAVR for older folks. But really, there's no discussion or even mention in the guidelines about valve-in-valve or TAVR and TAVR in the future, when the first device, whether it be surgery or TAVR, fails. And I think that's a really, really important point. And we tend to favor TAVR for older folks because, as you know, the TAVR trials involve folks that were over the age of 65. But also, it really comes down to how long the device is going to last relative to the patient, right? An older patient is probably not going to outlive their first valve, but a younger person probably will. And so these aren't really things that are typically addressed in the guidelines. And I think that going back to the traditional heart team, back when we first started TAVR, when you guys were fellows, you remember that the heart team had a really easy job. It was just, should we do a TAVR on this patient or not? And we were typically dealing with, high risk or inoperable patients. But now things have gotten a lot more complicated, right? So I think now, before we do the first intervention, whether it be a TAVR or a SAVR, we have to think about, if we do this today, what will this person's options be, or how will we treat this person, in the future when they come back with a valve failure, regardless of whether it's surgery or a TAVR. And I think that comes down to several factors, including anatomy. Will redo TAVR be straightforward, right? Does this person have difficult anatomy that if we put a valve in now, it's not going to be straightforward? We're going to have to do some sort of leaflet modification or maybe even surgery to remove the TAVR in some situations. Will coronary access be a problem, right? Both now and also if we do a future valve-in-valve. Durability issues, right? A very young patient might benefit more from a mechanical valve potentially versus a bioprosthetic valve. Hemodynamics, right? And there's a lot of discussion about hemodynamics, but we tend to focus on hemodynamics about TAVR valves and not so much about surgical valves. But if we're going to send someone for surgery, really the type of surgical valve that goes in actually, I think, matters. And we'll talk more about that. But surgical valves, the inner diameter is going to be smaller than a TAVR valve, and that may or may not have consequences. And if we do surgery, is that valve going to play well in the sandbox with the future TAVR? And then other considerations. Does the patient already have multivalvular disease that potentially could be benefited? Do they have multivessel coronary disease that potentially could be treated? And of course, we got to take into account patient preference. So it's got a lot more complicated now, than it did in the past. So there are a few concepts I think that are really important to think about when we're thinking about doing the first intervention. The most challenging cases I find in clinical practice, and I'm sure you guys probably have had this experience, is if we have a superannular device and it fails. Those are the most challenging to treat. And I think there's three concepts to kind of understand about this: the neoskirt height, leaflet overhang, and expansion of the index device. So what the heck is a neoskirt? Well, as you know, the leaflets of the first valve are going to get pinned open when we put a new valve inside. And that forms a solid wall on the outside, and that is called the neoskirt. And the height of that is going to vary depending on what valve we're treating, how high we put the second valve, if we put a balloon expandable in, how high we place that within the first valve, et cetera. And that has implications for coronary access, for coronary obstruction, if we do future valve-in-valve with another TAVR. Leaflet overhang is another issue. With a superannular design, the leaflets are high. If we place a balloon expandable valve deep inside, those first leaflets are going to overhang, and that may or may not have consequences. That could cause some hemodynamic issues, potentially some durability problems, and maybe even a residual gradient in some situations. And then finally, when we put a balloon expandable valve inside of a self-expanding prosthesis, the hourglass shape is actually going to get expanded radially, and that may or may not be a problem. It could lead to some coronary obstruction issues, and so that has to be taken into account. So these three things I think are important concepts to understand, and we can kind of plan for these things before we put the first valve in to see if this is going to be a potential issue in 7 or 8 or 10 years when the first valve fails. CT is, of course, the sort of the way we really assess these things. So if I'm doing a valve-in-valve case or a TAVR-in-TAVR case, I'm definitely doing a CT, and we're definitely going to look at those, at these important factors. So here's some examples of drawings. Obviously, this factor of the neo-skirt being a problem can happen with balloon expandable or self-expanding valves. But you can certainly figure out where the leaflets are going to end up and where that's going to be relative to your STJ and your coronaries. So if we end up with a neo-skirt that's above the coronary level and at the level of the STJ, and the STJ is narrow, we're going to have a problem. So that depends on several things: the type of valve and also the depth of implant. There's a strong tendency to deploy self-expanding valves as high as possible to avoid pacemakers. But the higher you go, the higher the neo-skirt is going to be when we have to, re-intervene on those folks. And so that's something really important to think about. Even in some cases where the first valve was placed low or deep, if the sinus geometry is short and the STJ is narrow, there's still some risk there. So what we do is we look at the coronary ostia and we look at the STJ. If your coronary ostia are above the wrist plane or the neo-skirt, you're going to be fine. If they're below the neo-skirt or the wrist plane, then we're going to look at that, valve to coronary distance. If it's greater than 4, you're probably going to, be okay. If you're in the range of 2 to 4, you're kind of in the watch out zone. And if you're less than 2, you're definitely, it's a substantial risk for coronary obstruction. And the same thing with the STJ. If your STJ is above the wrist plane, you're probably going to be fine. If it's below, then you really have to pay attention to that neo-skirt to STJ distance. And if it's very small, you got to watch out. So there are other factors that are important too, right? So not just the design of the valve and the coronary distances and the height of the neo-skirt, but also commissure alignment, right? So if the first valve was placed with a commissure right across the left main or the right coronary, and you're looking at potentially doing leaflet modification, that's going to be challenging, if not impossible, to be successful because of that. And obviously, over the years, we didn't pay much attention to commissure alignment, nor did we have much control over it. But the newer generation of devices are clearly going to take into account commissure alignment specifically for this, because of this issue, with the, concept that we want to keep our options open for potential leaflet modification or leaflet excision in the future. And that's going to be challenging if we have a commissure there. So that's important to realize. And when we're going to place the new valve in, looking at, what mechanism of failure, is the case for the first valve determines how we treat the second valve and where we place the next valve. And that's a really important concept. So just kind of looking at this, again, the top is balloon expandable, the bottom is self-expanding. If we have a case like this, situation here with the balloon expandable valve that's nice and low, large STJ, large sinuses, coronary ostia above the wrist plane, not going to be a problem. In the middle, we're kind of borderline, and clearly on the right side, even though there's flow now through the upper crowns, as soon as we place a valve inside there, those leaflets are going to seal off that location at the STJ and cause sinus sequestration. Likewise, on the bottom with a self-expanding valve, we see a similar concept, right? If the wrist plane is, this is a very, very low placed, self-expanding valve, as you can see. And so the leaflets will, when they're displaced, will be below the coronary ostia, and you're actually going to be okay. But if you look on the far right, there's no sinuses on this patient at all. And the device is placed, pretty high, which is what the tendency to do is. And there's really no place to displace those leaflets safely without obstructing the coronaries. So these are the most difficult cases. And I think it's important to understand the anatomy of this valve, right? So full displacement of these leaflets happens basically at node 6 to node 7. And you guys are all familiar with this, but node 0 by convention is the very bottom. And then the first kind of crosshatch is node 1, and et cetera. So to get those leaflets completely excluded, we'd have to make sure we get a second valve, a balloon expandable valve, and place the top of that around node 6 to node 7. But that neo-skirt height can vary. And that variation has to do with the size of the first self-expanding valve, right? If it's taller or shorter. And also, as you can imagine, if you put your second valve low down, you're going to have some more leaflet overhang and a lower neo-skirt. So the key is to understand the mechanism of failure of the first valve. If it's PVL or central AI, we can get away with putting a sapien valve lower down inside. In fact, we want to do that if it's PVL because the problem is the interaction between the patient's annulus and the valve. So in order to get that space to be expanded and filled up, we place the sapien low. If it's a stenosis failure, however, the leaflets of the evolute/core valve are stenosed. If we place the valve low, those stenosed leaflets will still exist above the valve, and we will have a sort of supravalvular stenosis problem and a potential residual gradient. So we have to place the valve higher. But then our neoskirt is also higher, and so that's an important concept. So why does this position matter? Again, you can have a variation in that neoskirt height anywhere from, or leaflet overhang, anywhere from 0% up to 94% overhang, depending on where in the inside the frame you deploy the valve. If you deploy it very low, you're going to have a lot of overhang. If you deploy it high, you're going to have no overhang. And again, this can potentially cause problems. If your leaflets of the evolute are pliable and normal, and you just have a PVL problem, you're probably going to have no issues initially. But down the line, those valve leaflets can still deteriorate. And so they're overhanging. And if they become stenotic or stiff in some way, that could lead to some problems down the line. This may be a new disease that we don't understand. We've not really seen that, but it may happen. So it's something to think about. So does leaflet overhang matter? Well, this has been kind of looked at, but really just on a benchtop model. So not in humans, but on a benchtop model, they have put sapien valves at various levels inside of a core valve/evolute. And again, it shows leaflet overhang varies. The only time they saw a hemodynamic problem was a 29 millimeter sapien inside of a 34 evolute placed very low. But again, the caveat here is this is a benchtop model, not in humans, and these are normal evolute leaflets. They're not calcified, they're not diseased. So we don't know, whether this is going to be a problem in humans long term if we're doing these kind of cases. So again, we're going to assess that neoskirt height depending on where we have to place the valve, and we're going to assess that relative to the STJ because a narrow STJ and short sinuses and a high neoskirt are a bad combination. And when we place the sapien, if we place it high up, we're going to get some radial expansion of the initial evolute/core valve, and that may or may not lead to coronary obstruction if there's a very small VTC in that area. So we have to assess that relative to the sinus geometry. So these are probably the two key slides that I want to kind of focus on here. If we're going to treat a PVL failure or a central aortic insufficiency failure, we're going to place the sapien low down inside of the core valve/evolute. So that's going to end up being sized essentially by CT to the patient's native annulus, essentially, because that's how the self-expanding valves are sized. The inflow sizing is sized to, the annulus of the patient. But the valve is, of course, much higher and is actually much smaller. So if we end up having a stenosis failure and we have to place a sapien higher, we're going to end up with a much smaller diameter sapien because the strongest portion of the frame, the most radial strength in the evolute/core valve frame is right at the hourglass, right where the leaflets are. So we also can't expand that area very forcefully very much because the nitinol prevents that because it's very strong in that area. So we will have to size the sapien to the actual opening of the valve, which is actually much smaller. So the trouble is when we put one of these self-expanding valves in, we don't know what the mechanism of eventual failure will be. We don't know if it will be a PVL failure or a stenosis failure. And if it's a PVL failure, we're going to end up with a reasonable size valve. But if it's a stenosis failure, the patient will end up with a much smaller size valve than they would have had if that valve had been placed sized at the patient's native annulus. So that's a really important point I want to bring up. So I just want to show a couple of cases that show some of the challenges that we're going to be dealing with more and more, I think, in the future when we deal with patients coming back with failed TAVRs. This is a 68-year-old patient of mine who had a 29 evolute placed 4 years before and unfortunately had progressive PVL. It went from moderate to severe and just got worse, and he became symptomatic. He does have coronary disease and had a stent in his right coronary, but he had Hodgkin's disease and had radiation to his chest years ago, so he's extreme risk for surgery and not a good candidate for that. And now his mechanism of failure is, of course, PVL. And if we go to the next frame, you'll see what I'm talking about. There's the stent in the right. There's a very small space. there's plenty of space on the left, but the space over here toward the RCA is very, very small. So the concern here is obstruction of the RCA. This patient is not a candidate for surgery, so it's not an option. So the only thing we can do here is do a snorkeled stent or potentially leaflet modification, but it's going to be challenging because there's also a commissure that's very close to that. So this is actually going to be a case where I did a snorkeled stent, and I'm going to kind of change my slides here a little bit so they play. So you can see the stent in the RCA, and you can see that the evolute was placed relatively deeply, and despite that, still potentially be a problem when we fix the PVL, because even though we can put the sapien relatively low down, we have to put it across the annulus to get rid of the PVL, and the height of the right coronary here is quite short, so it's still going to potentially be an obstruction issue. So what I've done is I put a wire extension down. So there's the tip of the guide extension over here in the mid RCA. And then I'm going to go ahead and deploy my sapien just below the level of where my guide extension comes out through that right coronary stent. Because if I deploy it above it, I'll definitely obstruct the coronary and I won't be able to rescue it. So once I place the sapien below the right coronary stent, then what we're going to do is then deliberately put a stent and kind of hang it out a little bit to deflect the leaflet of the evolute downwards to preserve coronary flow. And IVUS can be super helpful in these cases too, just to make sure that you don't have a leaflet that's obstructing. But obviously this is not an ideal scenario because God forbid this patient comes back again with a valve failure. I don't have an option to do another valve in valve because I'll crush over that snorkeled stent and obstruct the coronary. So that's going to be a problem, unfortunately. So this is another case. This is a 76-year-old guy with a 29 millimeter Evolute R that I put in 5 years ago, and we were part of the Evolute low risk trial. This guy's a very prominent lawyer down here in La Jolla. He didn't want surgery and he wanted to be in the trial, so we did an Evolute on him 5 years ago. Now he's got progressive shortness of breath. His echo shows his gradients are quite elevated, and we did a 4D CT that shows clearly very thickened and calcified leaflets. So the mechanism of failure here is stenosis. So you can clearly see on this still frame that the leaflets are clearly calcified and diseased. So now the question is, okay, what are we going to do about it? Well, unfortunately, this gentleman has very limited options. So his sinuses and his STJ, the geometry is such that if I exclude those leaflets by placing my sapien high enough up to get rid of the stenotic leaflets or exclude them, I will completely obstruct at the level of the STJ. So what we've done here, unfortunately, is taken a low-risk patient and converted him to a high-risk patient. So what options do we have to treat him? Well, the only options we have are going to be leaflet modification, and we'd have to do a double balloon-assisted basilica. We'd have to do the right side and the left side because both coronaries are at risk. This is a very complex, procedure. I don't have the skill set of Adam Greenbaum, so it would be a challenge. And there's also potentially some commissural alignment problems that might make it difficult. We could do a traditional open surgery where we take out the entire implant, but oftentimes it's very well incorporated at this point after 5 years, and it will probably require a root replacement, which can be done, but is a more complex surgery. Or we can do a hybrid surgery, so-called surplus procedure. So where we basically do an arteriotomy, go in there, and under direct visualization, cut out the diseased leaflets, but leave the frame of the evolute behind, and then under direct visualization, implant a sapien valve directly into the valve to get to treat the situation.
And Curtis, is that still a full sternotomy, or do you access it just like a direct aortic case?
No, it's full sternotomy. So basically, we have to go in, put the patient on pump, but then make an arteriotomy and go inside. And then instead of removing the valve, just cut out the leaflets. And then at the top of the skirt of the evolute, you put the top of the sapien valve. And so that will, get you a new valve and also allow future valve and valve with a second sapien if necessary. So this is what it looks like. I'm just going to play this really quickly. If I get it to play. There we go. So basically, we're cutting out the diseased leaflets under direct visualization, and then we place a sapien, with a C-arm or under direct visualization in the OR. So that's essentially how that happens. So it's
Curtis,
still surgery, but
it's doable. Surgeons to do this? Like, how did your surgeons learn how to do this? Did they have to go somewhere and learn the skill set, or did they kind of learn on the fly?
Well, that's a great question. So what we did is I kind of talked them into doing it. And then what I did is I found out a name of some names of surgeons around the country that have done it. And then I got their phone number and then connected my surgeon so they can speak surgeon to surgeon about the specifics of it to sort of get them comfortable. It only took about a 10-minute phone call for them to feel very confident with it.
Great.
So the last thing I want to talk about is this, which is I think it's really important if we're going to have a real heart team, we need to be academically consistent. Okay, so what do I mean by that? Okay, so this happens all the time. We get a patient like this. Let me just change my slides. Like this, who is 77 years old and has a area of 332. So if we look at our little handy dandy sizing chart, that sizes to a 20 millimeter S3 if we're going to do that. But we'll often get someone that says, I'm not going to put a 20 millimeter S3 in the patient. That's too small. I'm going to do a 23 evolute or I'm going to do surgery. Well, let's investigate that concept, right? So as I told you before, the actual opening of these valves is not the size that they, are marketed as. So a 23 evolute is actually a 20 millimeter valve. A 26 evolute is actually a 22 millimeter valve. 29 is a 23 and a 34 is a 24. So a 23 evolute is not a larger valve than a 20 S3. It's a 20 millimeter valve. And so if you don't believe me, here's some experiments I've actually done. So this is an actual evolute valve, and that I've actually cut the top off so I could get my calipers in there. And sure enough, the inflow is 23, but at the level of the leaflets, it's a 20 millimeter valve. Wow. So it is not a larger orifice. Now, if you don't believe me, you can also ask Medtronic. This was something that was sent out to all of us that have done these valves in the past. This was an urgent field safety notice a few years ago. What was happening is people were doing a post-dilatation and they were using too large of a balloon and then tearing the leaflets and causing problems. So Medtronic sent this out and said, well, here's our 4 sizes of valve. This is the largest size balloon that you should use. And sure enough, it's a 20 millimeter balloon for the 23, a 22 for the 26, a 23 for the 29, and a 24 for the 34. So they're telling you here, spelling it out, that that's the actual size of the valve. And that's actually what we know from the geometry. So, it's very important to understand how different valves are sized. We know that TAVRs are sized by their outer diameter because we look at the annulus and we're using the CT, and that's what we're sizing them by. But surgical valves are very different. The way a surgical valve is sized is totally different. The surgeon goes in and opens the chest, removes the old valve, decalcifies the aortic annulus as much as they possibly can, and then they're handed a tray like this of sizers. And they find the one that fits in there as tightly as possible, and whatever number is on it, 24, 26, they'll say, give me a 24 or 26 valve. That's basically how it's done. Now, the same doctor that said, I'm not going to put a 20 millimeter S3 in there because it's too small, says, well, I'm going to do surgery instead. No problem. But remember, by the CT, it's sizing for a 20. So at most, you're going to get a 21 millimeter valve because it's, again, the outer diameter is, close to 20, so it's 21. Depending on what brand of surgical valve the surgeon chooses, you can have an inner diameter of 19 if you use a Magna or a Paramount, or as low as 16 and a half if you put in a Mosaic valve. So the same surgeon who said, I'm not going to put a 20 millimeter S3, I'll do surgery, and then puts in a 21 Mosaic is actually putting in a 16 and a half millimeter valve, which is totally academically inconsistent with the whole concept of sending the patient to surgery in the first place. So I think it's really important.
That they like to say they're going to do an LVOT enlargement too, but we know those are probably like less than single-digit percentage on who actually ends up with an LVOT enlargement. I'm
glad you brought that up because unless you actually do a root enlargement on that patient, you're not going to get a larger orifice than you are by if you put a TAVR valve in. It's just not going to happen because you have to have a sewing ring or some structure there to attach it to. The Inspiris valve is a lot better, but it's still, not going to be quite as large on the inner diameter, although a lot better. But my point is, as cardiologists, we tend to look at a patient and say, let's talk about TAVR and the specifics. But once we decide to go to surgery, all we say is SAVR and move on, but we don't talk about the specifics of the SAVR. What brand of valve, what type of valve. If the patient goes to surgery, we want the biggest internal diameter possible. We want a valve that's going to be suitable for valve-in-valve TAVR next time. If it has to be a small valve, that's fine, but make sure it's fracturable, right? So we can make it larger. Don't give us one of these valves that has leaflets on the outside like MitraFlow. Fortunately, Trifecta is now off the market, But for a while, we were dealing with a lot of those, and they're not fracturable, and the leaflets are on the outside, and they have a very small inner diameter, and they're really not favorable for valve-in-valve TAVR. And we would like them to avoid these, valves that don't have stent frames, like homographs and stentless valves. Those are challenging for us. So I think we can't just say SAVR and move on, that if we're going to talk the details of TAVR, we should also talk the details of SAVR for each patient and think about these things.
Yeah, Curtis, I don't know if you've seen, but I've seen on these valve-in-valve cases where it'll be like a 23 surgical valve, and you measure right underneath it, like the LVOT, and it's like you could easily put a 26,
Absolutely.
Valve in here. And it's just a shame because now you're got this small ID and you're trying to shove stuff in there. So
right. No, absolutely right, Aiden. And this is another thing is, I'll hear surgeons say, oh, I put a nice big 25 valve in, which sounds really big. But again, if they put in a mosaic 25, it's only a 20 millimeter valve. It's 20.5 inner diameter. And I think that's important. You brought up a really good point, is that if this person comes back with a failure of their surgical valve, and we do a TAVR, we have to make sure we do not put a valve in that's based on the outer diameter or the advertised size. So let's say you take a 25 surgical valve and say, I want to make it bigger. I'm going to put a 26 valve in there, a TAVR valve. This is what it's going to look like, right? It's going to be constrained. It's going to be pinwheeled. You're going to have leaflet redundancy. And this is going to lead to early halt and valve failure. And we're dooming the patient to failure. So when we're doing these valve-in-valves in the future, we have to ignore this false sizing, which is all OD, and look at the inner diameter. That's really what we're working with on the TAVR side of things. And although we have this psychology that bigger is better, bigger the number, the bigger the opening, not necessarily true. Putting a 26 valve in this patient is a disservice rather than putting a 23, which would be appropriately sized. So even though it sounds bigger, it's actually not, and it will fail sooner. So I think that's a really important point. So anyhow, those are kind of the topics that I want to talk about, and I really want to open it up to discussion with you guys about your thoughts on these topics and and what you've experienced in your practice.
Yeah, no, Curtis, I love that. That scares the hell out of me. All these evolutes are going to come back with valve failure, but now we're equipped with the ammo to treat them appropriately, and that was a really eloquent overview of it. And to be honest, I've always been very confused whether to put it at the inflow or at the level of the valve, and that's a very articulate kind of way of describing it. So I learned you always have a reason for everything you do in the lab.
I try.
I know historically you liked core valve and you were implanting that a lot, but you recently had a change, and Scripps is one of the largest TAVR centers in the country. What was the impetus for your change? Was it this concern over lifetime management and coronary access, or how did you shift your mindset in terms of becoming more Edwards predominant?
That is a really good point. So I think it's a number of factors. So as you point out, I did hundreds and hundreds of Medtronic valves, and what I found is that, number one, the cases were more difficult sometimes, right? To get the valve to go where I wanted it was sometimes more challenging. Number two, some of these early failure experiences, as I shared with you, coming back, made me think about it. But we still were kind of on the concept that the hemodynamics were better, and so we really were still focusing on that. But to be honest with you, that's a whole nother discussion. But once I realized the structure of the valve was physically smaller, the hemodynamic advantage really made even less sense to me. How could a 24 millimeter orifice have better hemodynamics than a 29 millimeter orifice? The 24 meaning the 34, which is actually a 24, didn't really make any sense to me. And so after I started reading those papers and diving into the physics of what's going on and the Bernoulli equation and how Doppler works and echo, I realized that it's really just an echo-based phenomenon, that when there's a valve that's smaller, if it creates turbulence, we're not seeing that high velocity by echo because of the turbulence, and it makes it look like the gradient's lower, and hence we all associate that with a better performing valve. But really it doesn't add up when you look at the clinical outcomes and you look at the trials of these devices. Those lower echo numbers didn't manifest as better clinical outcomes. And so once I realized that the hemodynamic advantage really wasn't there, and the cases were more challenging, the pacemaker rates were higher, and the difficulty treating it when it failed, I realized, I stopped and thought, what am I doing to my patients? What am I going to do for this younger gentleman when he comes back? How am I going to fix this problem? And so it really got me on this path of trying to learn more about the anatomy of this and thinking about how can I predict, difficulties I'm going to have next time when the valve fails, and how am I going to address those? And it really got me thinking about this. And so that really has changed me to using, shorter frame devices to avoid these types of problems.
Yeah, no, that's great. And then one more question. When you're planning your TAVRs in your native AS patients, so not valve and valve TAVRs, do you have a process or kind of a workflow on your CT where you're looking at STJ, risk plane, and are you routinely doing that? Or like in an 80-year-old, are you just saying, let's just get the valve and make it look good?
That's a great question. That's a great question, Joe. So I think that's where there's opportunity for improvement in the heart team in general at all of our practices. I think that, I don't want to use the word AI, but I think some sort of process where we take a given patient's native CT before they've had any procedures, and we sort of put in what we propose to do, a 23S3 or a 25 surgical valve or whatever of brand X. And the simulation shows us, and it shows us what those different dimensions and geometries are going to be that we talked about, and will give us sort of a green light or a yellow light or a red light. And that will make it easy for people to say, okay, we shouldn't do this because this patient's only 68 and we're getting a red light across the board here. If we do these devices, maybe we should do surgery on this patient. I think that will help us as a heart team to make these decisions and catch these things, because these are very nuanced things that you and I are talking about right now. And I think a lot of really good skilled operators don't necessarily think about all these things or know about these things. But to answer your question, what I do now is if it's a very elderly patient that I think is probably not going to outlive their device, I don't really think about it, to be totally honest. But if it's a younger patient or anyone that seems like they potentially could outlive their valve, I sort of do my own little virtual valve assessment on what I think I'm going to put in the patient and see if that's going to be feasible. And it'll also direct me kind of on my implant depth. So for example, let's say I'm going to plan to do a 23S3 on a patient. If I do a 90-10 implant, the top of the frame might be contacting the STJ, and then a future valve and valve will be complicated because it may obstruct at the STJ, versus if I did an 80-20 implant depth, then I have space around it, and my second valve and valve will be very straightforward. So I kind of do my own little quick and dirty simulation, if you will, to kind of look for those things, and then I'll go into the lab with a little cheat sheet saying, here's my angle of deployment. I want to go for an 80-20 or a 90-10, whatever it is, based on the patient's anatomy. Or if it's a failed evolute, saying, land this at the top at node 5 or node 6 or whatever. So I kind of have a plan. So it's not perfect yet, but I think there's an opportunity for sort of a software program or something to make it easier for us guys that are not computer savvy IT experts to do a quick and dirty assessment when you're assessing a younger patient to help us make decisions.
Yeah, I could have done the same.
Go ahead, Aiden.
I put in ellipse and then kind of look distance to STJ, how big are the sinuses? I think in a young person, that's important. The one question I have is, are we going to have devices that are specific? Is this something I will need to worry about? Because we just have some device that goes in and incinerates the old valve, and you can do whatever you want.
Right.
But I don't know. You're seeing some. I've done some cases where I know I could never get another valve in there, and you just hope that there's something that comes across.
Yeah.
You have any thoughts on that? Basilica, doing that on.
I do, but we'll do Basilica when it's feasible. I found that, again, the commissural alignment is a potential limitation, because even though you could potentially do Basilica on a given patient, unfortunately, the first valve is not aligned appropriately, and it's going to be challenging to do that, and you end up with a snorkeled stent anyway or something, and it's not ideal. There are a few patients running around out there that I've had to do snorkeled stents on, and I'm very nervous when they come back. I don't have an option for them. So I don't know what to do. But I agree. I mean, I know there's a lot of smart people out there that are working on, like you said, devices to remove leaflets, incinerate, the apparatus from the inside of the valve. And I think those are going to be super important going forward. Hopefully they're easy to use and, are safe to do. I worry about hemodynamic instability, taking all the leaflets out, and you have to be very quick on the draw to put your new valve in. But I definitely agree with you, Aiden. I think that technology is going to have to work in that space to find some method to remove bad leaflets, so we can sort of reline the valve without the leaflet material being there.
Yeah.
Curtiss, you guys have been doing TAVR since the beginning. Have you guys seen a significant uptick in your TAV and TAV population in terms of percentage of patients you're treating? Because I mean, if you just look at the numbers, we're going to be seeing a lot more of these patients in the next 5 years. Like, what have you guys seen?
Yeah, it's interesting. I think that a lot of the, as you know, a lot of the TAVRs we did years ago were all very high risk patients, and many of them have either passed away or, you know, we haven't come across many of them. I have retreated a few of the SAPIEN patients from, you know, PARTNER 1 days that have outlived their valve. One gentleman in particular was in the PARTNER 1 trial as inoperable, even though he was in his like early 60s, because he had had radiation from Hodgkin's, and so he was inoperable. And he's otherwise healthy now, and so he did require a valve-in-valve. And fortunately, you know, the sinus geometry and coronaries were great, and it was like an easy peasy procedure. And it's amazing. The first one was like TA because, you know, that's what we were doing back then, and we had huge devices. And
26 for a guy, 23 for a woman.
Yeah.
It was general anesthesia. It was TA. So the guy has a scar, you know, over here. And this time it was TF and, you know, conscious sedation and home the next morning, and just a very different experience. So we have treated a few of those. We have sadly seen a fair number of evolute/core valve failures come back. You know, I hope that trend does not continue because it will be challenging. But statistically speaking, you're absolutely right. With the volume of TAVR in the country and the younger, you know, patients, all of our centers are going to see more of these folks come back. And so, you know, it can't be the situation where you know, put in the valve and be like, that's the next guy's problem. You are probably going to be the next guy, you know, unfortunately. And so it's kind of like putting in an underexpanded stent in a nasty calcified lesion and be like, you know, some other guy will take care of it next year. Chances are it's going to come back on your doorstep to deal with. So I don't know. I do lose sleep about that. I'm worried about that. I'm hoping that, you know, like Aiden said, technology gets up to speed quickly, so we have some slick way of getting rid of those leaflets sooner than later, and not of, you know, basilica works, but it's complex. It's not, you know, perfect. And sometimes I'm not 100% sure that I'm not going to obstruct the coronary. It's not ready for prime time. So having some device that simplifies it for, you know, dumb guys like me really definitely will help. So technology isn't there, but I'm really hoping that we get there.
My last question, I know you have a great saying about something about a host and a guest when it comes to valve-in-valve TAVR. I've heard that, don't you have some sort of great analogy? Like you're hosting a party and then there's a guest at a party. What is this? There's
probably, sort of I don't know. I have a lot of those random sayings. I don't even remember what it is.
I love it. Well, Curtiss, thanks so much, brother. This was a great talk. And really,
thank you for having me. Keep up the great work with Murmur. It's really you guys are doing a great thing for you know, cardiology in general, and for all of us to be able to communicate and share ideas. That's how medicine advances. So kudos to you guys for all your hard work.
Awesome. Thanks, Curtiss. See ya.
Thanks, Curtiss.
Bye.